Hi, well, welcome to episode 4 of Let's Fix the NHS. We're here with Dr. Nadia Masood, a former anaesthetist who is active on TikTok, Saha's Life on TikTok, and who we had a great discussion on Friday, didn't we, Nadia? Can I call you
Yeah.
Nadia? Is that okay?
Yes, yeah, that's right.
Fantastic. So what we wanted to talk about really is the state of the NHS. Obviously, the junior doctors, the resident doctors have just voted for a strike, or they've gone on strike a few days ago. Nadia was active for, I believe, over 20 years as an anaesthetist and consultant, but took the decision to get out of the NHS in a previous role for various reasons. And which she talks about on her TikTok page, and talks about general life and other issues. And although getting out of conventional medicine and the role that she trained for is something that some people might question, there's very good reasons that she's done it, and she's doing something again with that medical training that has equal value, has important value around occupational medicine. Isn't that right? So Nadia, welcome. Thank you for
Thank you. Hi.
joining me on this, and thanks for taking a look at the material about Let's Fix the NHS. We can talk about that later on. But maybe, just to start, you could do a bit of an introduction of yourself and your background and decision to get into medicine. And as we discuss things, we'll talk about the decision to get out of the NHS role that you had.
Yeah, no. So I started working in the NHS in 2004, and I decided I wanted to be a doctor when I was 16, 17, the age when you're at school, you're in sixth form, and you're having your careers guidance to help you understand what you might want to study at university, what are you going to be applying for. And actually, I very much shied away from being a doctor because I felt like it was just the typical route, especially for a lot of Asian people. They all expect you to become doctors. And I thought, oh, I don't want to do that. But I was doing this questionnaire that you had to, I don't know if people remember, this is now going back over 20 years now, but there was this software that you answered lots of questions about yourself. What are you interested in? What do you like? And I did it about 3 times, and it kept telling me that I should become a doctor because I was interested in science and helping people. And then eventually I thought, okay, fine, I conceded. Okay, fine. It does look like on paper being a doctor is what will suit me and what my aspirations and the goals are. And it's a big decision. A lot of people don't realize, doctors, we're making these decisions to study medicine when we're 16, 17 years old. We're still children, really. We're teenagers, and we're making these massive life-changing decisions. But, I loved it, and I went to medical school, finished medical school, became a doctor, and actually really, really
Where did you
enjoyed.
go? Where,
I studied at St George's in London.
okay, right. Okay.
Yeah, yeah.
Um, what is your background? So what's your family background? Whereabouts did you grow
Yeah.
up?
So I grew up in Essex, and my family were immigrants. I came from a working class family. I was the first sort of generation of British Asians here, very, very big extended family. And as first generation myself and my cousins, siblings, we were all encouraged by our parents to get an education and really aim for a professional life. Our parents never had that, and they really felt that it was very, very important for us to get a solid education and really for that stable, secure future, aim for professions and jobs that offered that security and stability, because I think through their experiences they hadn't done that, and they didn't want that for us. So it was really drummed into us that we really needed to do that. And yeah, that's what it was. So I was the first sort of in, the doctor, although actually my dad's brother was a doctor back in Pakistan. So I wasn't the first in the family, but I was one of very, very few.
And siblings? Do you have siblings?
I do. I have 2 siblings. Yeah, I'm the oldest.
Okay, right. And do
I'm the
they
only
do?
doctor.
And the only doctor. Okay, interesting.
Yes, yes, yeah.
And so you got into medical school. You went to St George's, which is, if people don't know, it's Tooting, isn't it? Is that right?
It's Tooting, yes, yeah.
Tooting Wandsworth, sort of. Actually,
Yeah,
my brother a long time ago, 4 years ago, I think, had an operation there for
yeah.
hypertrophic
So it's a big.
myopathy. Yeah, and he He was a specialist. I think it's one of the leading hospitals for that
Yeah,
heart problem. So,
yeah.
um,
So it's one of the big hospitals in London, along with, in that sort of area of London, it's St George's, and then you've got other big hospitals like King's College and the Royal London. So there was it was at that time it was called St George's Hospital Medical School. It's now called St George's University. It's the same sort of thing, still the same
right. And what
place.
was it like? What was your experience at St George's like? And obviously, it starts off general, and then you specialize. And
Yeah.
just talk me through that sort of that career pathway, if you don't mind.
Yeah, so it starts off general as you say. So the first 2 years are lectures and book knowledge, and then the last 3 years are spent with time getting clinical experience on the ward and learning how to apply the knowledge that you've been learning and are still learning along the way, but how to apply it practically in the practice of medicine. And I enjoyed it. I probably did enjoy the clinical experience more because I felt like just reading books and learning facts, it's very hard to sort of retain that information. But when you can actually see how it's being applied in daily practice and how to use those knowledge and skills, then that's a lot more easier to remember, and it feels more useful knowledge to have. Knowledge is only useful if you know how to use it. So yeah, no, I enjoyed it. I didn't really know what I wanted to do in terms of specialty training until I think the final year, when I was trying to decide what I might want to do. And actually, I feel that we weren't really given much or enough information about what options we had. And I kind of felt like, for me, I felt like my options were medicine, surgery, or general practice, and I had to choose between them. And I didn't want to do a traditional office job. And I felt like a lot of medicine and general practice was just sitting behind a desk. And I wanted to do something that was more practicing medicine practically. But I wasn't keen on surgery either because I didn't fancy standing around for hours on end. It didn't look appealing. But whilst I was in, the surgical rotations, I looked over the drapes and I saw the anaesthetists. And I was really, really intrigued by their job. And I just saw them everywhere. Everywhere I went in the hospital, there was an anaesthetist there, medical cases, surgical cases, in A&E, in critical care. They were there, they were doing everything. And I loved that they had such a variety in the work that they did, that it was very, very hands-on. And it was a little bit of medicine, a little bit of surgery, a little bit of everything. And that's what really drew me to the specialty.
For people who are completely unaware, and I'll put my hand up, I am unaware of most things. What is an anaesthetist?
So generally, the majority of an anaesthetist job are the people that most people know us as the people that put patients to sleep for their surgery. And that is the majority of the work that we do. We also play a role in intensive care and critical care. And the reason is because ultimately what anaesthetists do is they have a very deep understanding of the physiology of the human body and what keeps it going and what might prevent it from working properly. And how to manipulate that physiology. And that's where the anaesthetic for surgery comes in, because we're manipulating people's bodies, we're putting them to sleep, but we're not killing them, but we're putting them to sleep and we're making them unaware of the fact that they're about to have a massive trauma. Surgery is a big trauma to the body. That's why people need to be asleep to have it. And so we're manipulating people's physiology to do that. So whilst we can manipulate it to do what we need when people are having surgery, in the same way we can manipulate it when there are things going wrong. And that's where it becomes relevant in critical care and in pain control. So you'll see anaesthetists administering epidurals in the labour ward and providing anaesthesia for cesarean sections in the labour ward, and in accident and emergency as well, if somebody's had a massive trauma where their body's various organ systems might have suffered damage. Again, we'll be going there because we know how to fix things at that level of, the functioning organ, so within the body. So if you think about it, when surgeons are fixing things like hands-on, how to actually fix something practically and physically, what anaesthetists are doing is learning how to fix things on the cellular level, and what drugs are going to have what effect on this part of the body. So yeah, it's that intimate knowledge of physiology and how to manipulate it, either to have surgery or to help somebody survive and live through any kind of a trauma. And ultimately, that's what we do. But yeah, the majority of the work on a day-to-day basis, most people will see that we are putting people to sleep for their surgery.
But it's a lot more in depth, isn't it? And not always are people asleep. A lot of
No, sometimes,
brain surgery or
yeah,
heart
yeah,
surgery, people are awake, aren't they?
yeah,
Explain that,
yeah,
because
absolutely. Well,
it's kind of freaky, isn't it? The
it
concept
is.
of being spoken to, and sometimes it's necessary for the cardiothoracic surgeons for them to see how you're responding, and for the brain
Yeah.
surgery.
Mm.
Yeah, talk me through that. That's fascinating.
So with anesthetics, it's not as simple as you go to sleep and then that's it, all your senses are obliterated. Obviously, your senses and your awareness are two different things. So we can affect people's sensory perception without affecting their awareness. And that's how local anesthetics work. They work at more of a local level where they will numb a body's response to pain. And yes, there are lots of surgeries that are performed on people awake, either with local anesthetic or with drugs that can impair people's sensory perceptions without impairing their level of consciousness. So it's two different things. In anesthetics, we have something called a triad of anesthesia. This was one of the very first things that I learned. And it's about awareness and then pain control. And then there's an optional third one, which is muscle paralysis. And that's where you get these movies where people are paralyzed, but they're aware because of that triad where they might have had the drugs to paralyze them, but they haven't had the drugs to make them unconscious. So there's drugs we give to make you unconscious. There's drugs we give to make you not feel pain. And there's drugs we give you to paralyze you, to stop you from moving. And you can do those in a different combination. So the surgeries where people are awake, it will just be the pain. We might not give the other two. We're not going to paralyze you if you're awake. So, or, we may give all three, or we may just give the two. We don't paralyze people for every single surgery either. And I don't want to get too complicated because it is quite nuanced, but yeah, essentially
But also,
that is what we do.
there comes a point where you wake people up, right? And
Yes.
how does that work? Again, that
So,
sort of coming out of that, whether
yeah.
it's general anesthetic or...
Yeah. So there's two ways really. If you think about when you take paracetamol, for example, you need to take it again because the effects of the paracetamol have worn off, and that's to do with how your body is metabolizing drugs that you've taken. So, that's to do with how your liver and your kidneys work, and how your body has processed that medication. So when we give an anesthetic, in the same way as when you take paracetamol, it will have an effect for a period of time, and then that drug will become broken down and it will be eliminated. And there's different ways of eliminating drugs from the body. So it's understanding what we call the pharmacokinetics and the pharmacodynamics, which is how our body processes and metabolizes medication. It's understanding how the body is going to do that and how we can keep that level what we need it to be. So we keep giving more anesthetic to keep that level of anesthesia going, and then we know when we stop giving it how long it's going to take to wear off. So it's about timing that. And there are sometimes drugs that we can give for some anesthetic medications that can reverse the effect, like the antidote, but there's not an antidote for everything. A lot of the things you have to wait to sort of work their way out of the body naturally. And a lot of anesthetic drugs that we use, for making people unconscious, they're very, very short acting. They don't last for a long time. So if you give it and then you don't give it again, that person will wake up quite soon.
And when things go wrong, why do they go wrong?
They can go wrong for a number of reasons. Everybody's body is different. We try and get as much knowledge as we can about how somebody's health is, what their health is like, how well their body is functioning before we put them to sleep. Because, like I said, in terms of things like how strong your heart is, when you're having surgery, as I said, it's a massive trauma. We say it's putting as much trauma in your body as it might be if you're running a marathon. You need a lot of stamina. Even though you're asleep, your body's stress responses are going to be through the roof because you're having a physical trauma applied in the form of surgery. And if you think about that in the same way as any other kind of stress response to somebody, if their heart is weak, they may not be able to withstand it. So we try and understand that. And then we try and make sure that any drugs we give aren't going to make that any worse. In the same way as, similarly, for example, if somebody has got kidneys that don't work very well, they may not be able to excrete a drug as normally as somebody with. So again, that might mean that the drug is accumulating in their body, and we need to be careful about how much we're giving them so that we don't give them too much, because they've actually got more in their body than we think because they've not got rid of it in the same way that somebody with normal kidney function might have. When something goes wrong, it's usually an unexpected, everybody's individual, everybody's bodies work differently. As much as we can try and understand and prepare for things, things can still go wrong in surgery, although it's very, very rare. As time has gone on and we've understood more, the chances of something going seriously wrong in surgery to the point that we can't fix it is incredibly, incredibly low. Usually things are going wrong in other areas, like I said, in trauma and A&E or in critical care, where somebody is already unwell and we have done everything we can try and do, but, it requires the body to respond to our efforts as well. And if the body stops responding to what we're trying to do to help it keep functioning, that's where things can go wrong.
And what are you looking at to understand, to monitor? Are you just looking at general stats, so blood pressure and oxygen?
Everything, yeah. Yeah, we're looking at a lot of things. We're looking at the vital observations. So, like you said, blood pressure, oxygen levels. There are other ways that we can monitor people's vital functions through blood tests and other types of tests. Some are very invasive and some are less invasive. So there's a lot. We're looking at more than one thing. We're not just looking at one thing in isolation. We're looking at the picture of everything. And then we're also looking at the trends. We're looking at how the response is going over time. So, for example, trying to put it in a simpler way. So if somebody's really, really dehydrated and we're giving them some fluids to rehydrate them, we'll be looking at how they respond. So when somebody is very, very dehydrated, I don't know if you've ever had this, the heart rate can become faster. That's one of the earlier signs. Their blood pressure can drop. That's why people say, oh, I had low blood pressure because I was dehydrated. So we can look at those things. And sometimes the response might be temporary. So it kind of helps for a little bit, but then actually kind of that effect has dropped off. And then we think, okay, we need to give them more. So yeah, we're looking at the response to the interventions that we make to assess how well those interventions are working. And then if we need to rein it in a bit, or if we need to give a little bit more of a push.
Now, what do you love about it? And what did you not love about it? And also, where did you start your actual career? So you did your training at St. George's, and what was that sort of career path? And I guess there's a few questions lumped in there, but I'll let you go with it.
So in terms of how I started, so I graduated medical school, and what we have to do, every new graduate has to do a couple of years of general sort of service covering lots of different areas in the hospital. So you're not doing one particular specialty. You'll tend to rotate. So I got my general experience. And then for me at that time, I had to apply to do specialty training in the specialty that I was interested in, which, as I said, was anaesthetics. Some way, sort of partway through my second year, I started looking at the jobs that were available for anaesthetics training and submitting applications for them. And you apply for those jobs in the same way, in competition with other doctors who also want to do it. There's not a space for everybody, but I was successful. So I started my anaesthetics training in 2006. It's quite a long anaesthetics training. Full time is around 7 years, but I did take a little bit of the scenic route. I took a couple of career breaks along the way for various reasons, and I did work part time, sort of towards the end, but then I kind of went back up to full time right at the very end just to get me over the finish line. So I finished all of my specialty training 12 years later in 2018. And that's what qualified me to work as a consultant in anaesthetics. So at that point, it was deemed that I had got enough experience, I had demonstrated enough competencies in the practice to be able to work independently as a consultant. What I loved about it, a lot of anaesthetists might say different things. For me, there was an instant gratification. As I said, when we look at physiological responses. So we give a drug, we see a response almost immediately or very, very quickly. And I loved that. I loved seeing that when I did something, when I was trying to fix something, I could see it being fixed before my eyes. And I loved that. I loved seeing the effects of the efforts that I was making. And I loved the variety, as I said earlier on. I loved the fact that I could work in lots of different areas and that I wasn't stuck just in one clinic room or doing one type of of medical work. I could work in theatres, I could work, I've spent time in accident and emergency for emergencies and critical care and obstetrics, pediatrics, so anaesthesia for children. It's a separate subspecialty because children's bodies work slightly differently, so they need to be handled slightly differently. So yeah, that's what I loved about it. It's very intense. You have to be on the ball the whole time, so your brain can never switch off. And that is very important. It's a very important part of the job and it's essential. You kind of need it, but it can become really tiring over time. And definitely I'd found it becoming harder and harder to sustain the older I got. And then once I had children, I found it even harder and harder. And alongside those changes within myself, there were changes in the system and the way that the system was working. It was becoming increasingly difficult. The pressures were rising. It was affecting us. So, for example, as I said, bed pressures, they did affect us in terms of how we were running the critical care, the intensive care unit. Intensive care is the most critical part of the hospital. It's where the sickest people are, and units are not, there's not a lot of beds, and people were getting sicker and we didn't have enough space for them. And there was pressure to get them out because more sick people were coming through the door. We didn't have anywhere to put them. I definitely recall in my time in training, I trained in London, which was very, very busy, very populated. I definitely recall as an anaesthetic trainee spending the entire night with a critically unwell patient in a makeshift ITU bed, which was usually in surgical recovery because there was no intensive care bed. They needed that care.
Sorry,
Yeah.
what's the difference with ITU and ICU? What's the...
It's the same thing. It's a different intensive therapy, intensive care, but the terms are interchangeable, but it's the same place.
Right. That all-nighter, and when we talk about fixing the NHS and bed pressure and the whole concept of discharge, that is a massive subject, isn't it? We'll maybe come on to it in a little bit, but those all-nighters, physiologically, how difficult is it to deal with?
It was for physiologically for me. It was you had busy night shifts. As an anaesthetist, were very variable. You could have very, very busy nights. We always used to say it only takes one. It only takes one patient to make you busy for the entire night because the care that we're providing is so intense and so hands-on, and you have to be there almost continuously with this one patient. It just took one, but the pressures are there's never just one sick person. So then there was that constant feeling of there's only one of me, but there are so many people that need me right now, and that's a lot of pressure to put on individual doctors. And what it meant was that other people were having to cope without my help, that I was having to call in help where I needed to. So often if I was in all night with one patient, then I was having to call in backup. So people that weren't,
Which
due
hospital
to be working. This was at various hospitals. I mean, in London, I trained all around different hospitals. I didn't do all of my training in one place. And generally that's how training works, is that you'll go to different hospitals because they all provide a different experience. So this was at one of the many London hospitals, and I worked in most of them it was in the northwest sort of location of London. So, but that went all the way over, to kind of not quite as far as East London, not quite as far as the Royal London, but yeah, a lot of hospitals. Can't remember how many in London, maybe 8 or 9. But I moved around, so I went back to some hospitals more than once for different reasons.
fascinating. And you're just constantly on the tube or the bus?
On the bicycle. Yeah, I
Oh,
started
right.
cycling a lot. I cycled if it was a safe route and it wasn't going to take too long, then I would cycle if the weather was okay. Although I did cycle in the rain as well, or I'd take the tube. I tried not to. We couldn't really drive. Driving in London is very difficult, so you can't really drive. The only time I would potentially drive was if it was a night shift or if I was going to be finishing really late, because then public transport options they weren't too bad, but I didn't always feel like it was the safest option for me as a lone female to be getting sort of tubes on my own at sort of 11 o'clock at night, or in the middle of the night. It kind of felt I felt safer in the car. And so but generally in London it was mostly public transport and cycling. I used my bicycle a lot. Used the cycle to work scheme, which was great.
Go back to the sort of number of patients that you might be with any one day, and certain ops and certain treatments would take longer, I'm guessing, and some could be very, in and out. How did that work? And you've got to see someone safe before you leave them, but someone else is going to be waiting for you. So are you
Hmm.
literally juggling all the time? I mean, is that how?
You are, and it's a team, it's a real team effort. So there's obviously in the anaesthetic team, there is the anaesthetist, we have staff, the nursing staff called operating department practitioners who are very, very skilled nurses who are trained to provide very, very good expertise and assistance to the whole theatre team, so anaesthetists, but also the surgical team as well. We have recovery nurses. So, for example, if you are seeing a patient, the whole pathway is, as you go to have a pre-op assessment. That will normally be done by the nurses as part of the pre-op assessment team. If there's anything complicated or complex, they might then ask us as anaesthetists to advise them. So we would see sometimes complex patients in a pre-assessment clinic. If the nurses thought that the health was a little bit more fragile, or the surgery was a bit more complicated, or maybe there was a history of problems with anesthesia. For any of those reasons, we might be asked to see patients in the pre-assessment clinic. And then on the morning of surgery, there would be the ward that you go to kind of get yourself checked in. Again, that's staffed by nurses as well, who sort of will get patients settled in and do some observations. And then we would go along and see them briefly in the morning of their surgery just to talk through the anaesthetic and introduce ourselves. Then in the actual procedure for surgery, as I said, we've got the operating department practitioners. Sometimes there would be one anaesthetist, sometimes there would be more than one of us. It depends on both the complexity of the case and also how many people are around that day. And then afterwards, we have the recovery bay. So again, that's staffed by nurses. You have to be available. So obviously, if the nurses are running into trouble, they're trained and they're very skilled at dealing with, some emergencies very, very well, but they are trained to call for help if anything goes wrong or if there's anything they're unsure about, then yes. And at that point you might be juggling, and that's where the team effort would come in. So there may be another anaesthetist around because obviously we're all in sort of a corridor. So there's lots of the surgeries going on at one time. Each surgical theatre has got at least one anaesthetist in it, if not more. So, for example, if I was needed in two places and I could only be in one, then I might call for help from another anaesthetist to say, can you either go and deal with that or come and take over because this one's a little bit more simple and I'll go and deal with that thing. So yeah, you are juggling lots and lots of different things and you're trying to prioritize who needs who the most, and between the team, delegating who's going to be doing what.
And you're record keeping at the same time, aren't you? I mean,
Yeah.
you have to,
Yes. Yeah.
there's a lot of note taking, I'm guessing.
There is, yeah. I mean, some of it, more and more of it was becoming electronics, and more and more was becoming sort of automated by computer systems. But there was a lot that you were still having to do by yourself manually as well, and prescriptions. So while somebody's having surgery, you're thinking ahead about what painkillers they might need after surgery and making sure that those are prescribed. And that might be based on how the surgery has gone. So you might be noticing that the surgery is a little bit more complicated. That looks like it's going to be a bit more painful than I thought. They're going to need a little bit of extra pain relief, things like that. So yeah, you're thinking of a lot of things at once. You're thinking of, the present, you're thinking of what might go wrong. As we mentioned before, things can go wrong. And when they do go wrong, they can go wrong very, very quickly and sometimes without much warning at all. So you have to always be ready and on alert to react and respond quickly. So you're always kind of thinking about that. And then you're thinking about, how the patient's going to be looked after afterwards. And then you're probably thinking also about the patient that's going to be following them. Do I need to get anything ready, anything prepared for them? So yes, a lot of juggling and a lot of teamwork.
You mentioned pre-op, and part of that is really about getting ahead of things, isn't it? Really to try and
Yeah.
avoid challenges
Yeah.
before they occur.
Yeah. Absolutely. It's just about knowing what you're going to be facing on the day, so that if you can try and anticipate any problems before they happen and be prepared for them. It's all about having your plan, your emergency plan before the emergency has even happened. And it's about using the knowledge of knowing what could go wrong, when it could go wrong, and how it could go wrong, and then what your plan is to deal with those things.
And in terms of complexity, I guess, would it be true to say that major trauma, road traffic accidents, things like that, are where the biggest complications occur, or is it elective, or where Yeah.
It
Whereas
could be
what do you
anywhere.
think
Yeah.
most of the
Yeah.
time?
So complexity, it can be, I think it's very, very dependent on the individual. So you could have a very, very fit individual involved in a road traffic accident that that is so robust physiologically that they don't need as much help. And you could have somebody else very, very frail that's having a very, very simple procedure like bunion surgery, but actually they need a lot of medical care to even be able to get through that type of surgery. So it's very dependent on the individual and our assessment of them, as well as what is happening around them externally.
So from a perspective of efficiency of the system, and go back to the things that you didn't like,
Yeah.
or that you found challenging
Okay.
about, I guess maybe the question is, what percentage of efficiency did you think that you're working at in that hospital environment, in that surgical
Mm.
and non-surgical environment? Because of the system problems, what
It
was getting
definitely,
in the
yeah.
way?
Yeah, it definitely varied from hospital to hospital, shift to shift, day shift to night shift, weekends to weekdays. The things that frustrated me about efficiency sometimes was the lack of understanding of the complexity of every single case that we were doing, and that no two cases are the same. So one knee replacement is not necessarily going to be exactly the same as another knee replacement, because as I just said, it's very dependent on the individual, not just the type of surgery that somebody is happening.
Lack of understanding from
From the people that were deciding the lists, I suppose. There's a thing on surgical lists where they sort of write the expected time, and we all kind of joke that it's just a random number plucked from the sky. So they've decided that this surgery is going to take 90 minutes from start to finish, and they don't take into account the anesthetic time and the recovery time. Firstly, they don't even take into account that I might need to go for a wee, and that's going to take me 3 minutes. They literally will do 9 to 10:30, and then 10:30 you've immediately started the other thing. They don't take into account that a certain stage of somebody's anesthetic or their surgery might take longer. I don't actually know how those times are calculated. And again, there wasn't really a lot of transparency, but we were just kind of given this, you're going to do this many cases today. And you kind of felt very, very constrained. In England, and I did all of my training in England, and then I moved to Scotland afterwards. In England, we had targets. There were financial penalties as well for not meeting targets, which I don't think are in Scotland. I think it works slightly differently. I still haven't quite fully got my head around the differences, but I do understand one of the main differences in England was that a lot of trust funding came from meeting certain targets, getting a certain number of cases done. And if you didn't, then they wouldn't get as much funding. And obviously that's a lot of financial pressure for the trust. So then that pressure was then obviously handed down to us, in that we have to get through a certain number of cases. And one of the frustrations for me definitely was frequently working unpaid overtime to get that number of cases done, to make sure that the trust wasn't financially penalised for it. And that was one of the frustrations amongst a lot of doctors around about 10 years ago, when there was the junior doctor contract dispute. It was around the fact that the NHS was relying on and running on a lot of goodwill being provided, a lot of work being provided for free by not just doctors, but actually lots of other healthcare staff. But at that time, there was a proposed new contract, and it wasn't taking into account the fact that we were already doing a lot of work for free. And now suddenly their contract was demanding that we do a lot more work for no extra pay. So, there was this proposed 7-day services plan at that time. This is back in 2015. And
this would be 3 years after the 2012 reforms,
yeah.
which I guess were starting to
Yeah.
be established, but there's a lot of controversy around them, right?
Yeah, yeah, absolutely. And the frustration that we felt was we're already working, you're already working us to the bone. We're doing lots of work for free. We're doing absolutely everything we can to keep patients, to keep that revolving door of patients coming in, we're fixing them, they're going out. We're doing absolutely everything we can. You're trying to burden us and trying to make us work faster. And people were burning out. I definitely had experiences of burnout in my career, and lots of people were. And I think it was the final straw when, at that time, they were proposing a new contract that didn't address any of those concerns that we had. And the contract reforms that followed eventually, once there was a period of us going on strike. And I think, I can't remember, Steve, if that was the first time junior doctors had ever gone on strike or not, or if it was the first time in a long time. But there was a lot of media attention around that time because we hadn't gone on strike before, at least for a number of years, if ever, and we were suddenly going on strike, and there was a lot of media attention at that time. And it was ultimately the contract reforms that followed that whole thing did promise to take into account some recognition for the extra work that doctors, because it was a doctor's contract that at that point was being disputed, that doctors were providing, and trying to make sure that they were going to be appropriately, that the extra work that they did was going to be recognised. I wasn't a junior doctor for much longer after that because it was right at the end of my training. So I probably am not the best person to say whether or not I think that that new contract worked and how resident doctors are finding it. Are they getting paid for working overtime? Have pressures eased off? I don't know. I feel that because of other changes that have happened in the NHS, we're all aware that actually the pressure on the NHS as a whole has definitely increased, and people are still struggling to keep up with that pressure. And I don't know how much their efforts are being recognised. And I think that's what's, causing some of the current issues with resident doctor pay, is that they don't feel that their efforts are being recognised or appreciated. The fact that they are trying to keep a system going, that the pressure is just increasing and increasing.
I guess my question is, when I mention percentage efficiency,
Sorry.
sometimes things get in the way, right? What I am thinking about is the stuff that prevents people delivering.
Yeah.
So we talked about beds and
Yeah.
bed pressure. So when when there aren't the beds in IT or ICU,
Mm.
because discharge is not occurring as it should do often. But when I talked to Sir David Haslam, we talked about the fact that quite often NHS services are not provided to people in a domestic setting or a care home setting.
Yes. Yeah. Social care is a big issue. Yeah.
20-30% of beds are, and I don't know whether that number's accurate, but still, even if it's 10%, if people are staying in hospital longer than they need, essentially it backs up and creates a bottleneck. And that's just one aspect. Theatre availability, resource availability, other professionals, their ability. These other things get in the way of delivering the ideal number of cases. Is that a frustration, or? And
Very
again, we're
much.
speaking historically because you're no longer in that role, and we'll come to that in a moment. But was that something that got to you?
Yeah, definitely. It really annoyed me. Often, as we've said about bed pressures in critical care, again, bed pressures also affected elective cases. There were often times it was very frustrating for the whole theatre team, not just us as anaesthetists, for the surgeons, for all of the theatre staff, for the patients, for everybody really, that there would be patients who couldn't have their surgery because they needed an inpatient bed after their surgery. They need a bed to recover in, and they didn't have that bed to recover in because of this problem with discharge. And a lot of that was recognised. I did feel personally that a lot of that was because of the social the social care not being there for patients once they've left hospital, and that was preventing them from being discharged because they didn't have that care provision that they needed at home or in the community. Yeah, that was definitely a source of frustration for everybody, because it meant that you thought you were going to be doing a certain amount of work this day, you thought you were going to be doing these cases, you come in, you find out you're not, you're sitting around. Often there were times where you would come in, and this is where there was a real lack of efficiency, where you would come in being ready, everybody's ready to do the surgery, but because the patient doesn't have a bed and has no guarantee of having a bed, you can't start surgery on somebody if you don't have somewhere for them to recover afterwards. It's safer than not to start. For elective surgery, for emergency surgery, obviously you have no choice. You have to. If somebody needs it, if it's urgent, if it's life-saving, you have to. There were cancer surgeries. Again, they were prioritized because they were life saving surgeries. So, most effort would be directed at not cancelling cancer surgeries, because when you then had to prioritize, we've only got one bed. This patient, we've got person A that needs this cancer life-saving surgery, and we've got person B that needs this knee replacement. As much as that person who's not going to get the knee replacement is going to be in pain, they're not going to die. So that person unfortunately has to lose out. That's frustrating for the patient, who now has to stay in pain for longer. That's frustrating for us because we see them and we feel frustrated that we got so close to helping this person get better and we haven't been able to, and being frustrated because we knew that it was this, systemic disorganization and perhaps the way that the healthcare system was being managed at that time, and not being, healthcare wasn't being prioritized in the right way. The right allocation wasn't being made to where it needed to be. So that
It
definitely
must,
affected the inefficiency. I wouldn't be able to put a percentage on it, but what I would say is that it was something that I noticed becoming more and more frequent and more common over the years. Definitely, it was something that was getting worse and worse and worse. It was always there, but it was definitely something I noticed getting worse.
because if you think about it, and this kind of goes on to your new role, ultimately people are not going to work only for their pay, although that's a big part of it. But when they're asked to work, many extra hours. I think doctors work long enough hours, and clinicians anyway. And if they're asked to stay and to deliver an awful lot more, but there's been bottlenecks in the system that meant while they're in their work
Yeah,
time, they couldn't work,
yeah.
that is the definition of insanity.
So
Just drives
frustrating. Yeah.
me crazy.
It was, yeah, absolutely so frustrating. You arrive at work, I start work at 8, I get there just before. I don't do any anesthetizing until 10, and then I'm there until 2 hours after work. So I've done 2 hours extra, but 2 hours of that extra that I did during my working day was spent sitting around waiting for the go ahead to be able to do the job. And a lot of people felt frustrated about that. They want to get started, they want to get it. And it's that feeling of everybody works. Yes, like you say, we work to earn money to live. But when you're doing work, you also want to feel that your day has been productive. And it's really, really demoralizing to go home and feel like I didn't really achieve much today. I didn't get much done. I'm exhausted, but I don't know why, because I don't feel like I got a lot done. And those days were really frustrating. And when you have those days repeatedly, it affects you. And there's this concept of moral injury, which has been talked about and written about in more recent years, affecting healthcare staff, where it is that frustration. It's affected them. They've suffered this moral injury because they have felt so frustrated at being unable to deliver the care, that they have the skills and the knowledge to deliver, but they can't because the system's inefficiencies have prevented.
Okay, so we've just had a bit of a forced break, but we were talking about system inefficiencies and how frustrating it can be to go into work, to want to give your best, to and then find all sorts of absurdities that get in the way. And then at the end of it, you're asked to do a few more hours to finish off what should have been done, frankly, many hours earlier. And you
Mm.
talked about this moral injury. Just tell us a bit more about moral injury and your experiences then, and then we can get into your new career and the
Yeah.
reasons you decided to switch.
Yeah, so it's interesting. Moral injury has been written about in more recent years. And when the term was first brought about and publicized, so many healthcare staff felt, aha, like that's put into words how I've been feeling. Like somebody's finally understood it and now written about it. And now I can see it in black and white. It explains the feelings that I've been having. And personally, it was that frustration at system inefficiencies. It was feeling exhausted after work, but not knowing what you had actually achieved at work, because you'd spent a lot of the time maybe sitting around not doing any work, but you were waiting to do it. And then you were working extra to catch up on what you hadn't been able to do in your work hours. So you were still working overtime, but you hadn't actually gotten any more work done in that extra time. It was just the way that the time had been used during your work hours. It was about the inefficiencies of seeing people suffer because you couldn't give them the care they need. So seeing patients surgeries get cancelled, seeing patients not being in beds that they needed, and waiting around in A&E or in other areas of the hospital, not in the place that they should be where they could get the care that they needed to. and continuing to try to do your best for them in a system that wasn't very efficient, that wasn't ideal, that was falling apart, right, quite frankly. And that does have a real effect on the people who work in that system. It affects their mental health and it affects their morale. And over time, they become more and more unwilling to go into work. They don't want to go in and have to face that again. They don't want to go in and feel that way again. They just need a break from it. They're just exhausted. They're mentally exhausted from the stress of that. They're physically exhausted because they're still doing these extra hours, but they're not getting anything extra achieved in those extra hours. And that definitely has an effect on people when they're working in that system. The hours that we do are very intense, and then you're doing that for years and years and years on end. It definitely affects people and it wears people down. And it definitely does cause their own health to be affected, essentially, their mental health to be affected, and their physical health as well, to be honest. Very, very hard for healthcare staff to keep looking after themselves physically when they are so busy trying to keep the NHS afloat, essentially.
It's interesting. Hope is when I define it as when your actions or those actions of others working on your behalf will generate a result, an outcome that is satisfactory. And hopelessness is the opposite, where you feel that no matter what you do, nothing's going to change. No matter what anyone else working on your behalf is going to do, nothing's going to change.
Yeah.
And dark thoughts happen in those times, don't they? It's like,
absolutely.
and that's why the dedication of people within the NHS is just so remarkable, because they push past that and they still go in. So hope and hopelessness is really central to this, isn't it? And that's why I have so much respect for people who just push past these frustrations and keep on going. But stress is something that amplifies over time, doesn't it? And if you keep going in and still having these absurdities that you face, that's why tackling these issues is so important. And it's interesting, you talked about the people who write the list. That's something where potentially things like AI will help. But so we have better understanding of the timings and the flexibility and that. But my question is, what about people who are trying to create the change, and yourself included, surely tried to change things many times? What kind of pushback did you get? What kind of resistance? Or was it not your job to try and change things?
So I think the difficulty I had when I was doing my specialty training was because we rotate around a lot of hospitals, you're never in one place long enough to make any meaningful change. So a lot of the frustration came from there. And we are, as all resident doctors will say, part of our requirements are not just the clinical knowledge, but it is to understand how to improve system, and we have to do quality improvement projects to try and improve the quality of care. And so there were lots and lots of projects that people get involved with to help with inefficiencies. So I don't think it's so much a case of pushback against efforts, but it's about the efforts kind of feeling like you're just shouting into the wind, that nobody's actually taking any notice of the things and the suggestions that you might have. Also, the NHS is a very, very big system. It's a very complex system. So to try and change the whole thing, that's a lot for anybody to try and do. And I certainly acknowledge that. So generally, the more sensible approach is to identify this one tiny little area of service provision and let me just see if I can make that particular service more efficient. And that's where a lot of people focus there. And they can be very, very successful, but you need to be there long enough to see that change. And also it's like fixing one tiny little thing in that massive complex system. Overall, the effect of it's like a drop in the ocean. It might have helped that one little area of service provision, but it hasn't helped this NHS as a whole. So those frustrations are still there. And it's about the fact that the NHS it's not a static system. It's dynamic, it's evolving, it changes with politics, it changes with people's health, it changes with everything that's going on around it. So even if you implement a change and it's really, really successful, that doesn't mean it's going to continue to be successful. If the system changes, then that little thing that you did to fix it is no longer working. And so it's very, very difficult, I I think people acknowledge that it's very, very difficult to change. They don't know where to start. And then sometimes I think for healthcare workers and for doctors that are working clinically, you don't always have the mental energy or the physical energy to then be doing your job and trying to do your frontline service provision and be trying to make the system more efficient as well. You don't, who has the time or energy to do that? So then people are doing one or the other. So there are healthcare staff that get involved in management, but then you're away from the coalface and you might not be, like I said, it's an evolving system. So then they might not be up to date with actually what the problems are. They might think they know what the problems are from when they were at the coalface, but now if they haven't been in it for 5 years, they're not up to date with what the current problems are.
Nadia, what do you think of this crazy guy who's got an idea called Let's Fix the NHS?
I think it's
Given what you
great.
just said, let me just frame the question a little bit more,
Sure.
because the reasons that you've given why change is so difficult inside an organization like the NHS, I think, are incredibly valid.
Mm,
And it is large and it's complex. People are delivering, they're busy delivering, and therefore to be taken out of that delivery to essentially look at creating change is in a way unnatural, because
yeah.
their head is in delivery. And sometimes when they're in delivery, they're not thinking about those system level things. They think about the
Yeah.
frustrations in the moment.
Yeah.
But the thing about system challenges is it's multiple parts of the system that all interact with one another. And the analogy is the human body, that in the role as an anesthetist, if the blood pressure kind of spikes, there are other reasons. And you mentioned it could be hydration, or it could be other things, or sorry, plummets. It could
Yeah.
be down to the water. And in a way, it's a fantastic analogy for that big complex system. We know that if care, which is almost completely unrelated to surgery, but if the people are having a stroke, as my mother, I don't know whether you saw from my story,
Mm,
my mother had her stroke, and she had 4 months in hospital, a month in the acute ward, and then 3 months in a rehab hospital, and then was able to come home to her home where I was able to look after her. But even that, there was delays in her discharge because the care that she needed couldn't be initially provided. So it might have just been a handful of days. But when you look at that, that ultimately has a knock-on effect, or somewhere back much, much further in the system, such as,
yeah.
and therefore the complexity around, or the frustrations around wanting to be delivering as many cases as you can every day. It might be the fact that my mum's there in the bed for 3 days, 4 days longer than she
Yeah.
should be, that other bed is not available. So it is difficult when so many things are not in one's control. And therefore, I think, that level of helplessness can occur because actually fixing the system has so many parts to it.
Yeah.
And therefore you try, in psychology, there's something called learned helplessness, isn't there? You try and do something once, twice, three times, and that's kind of enough, and you kind of accept.
Yeah.
And I guess that must occur a great
Oh,
deal,
yeah.
even if
Yeah.
people are trying, because there's so many factors that are working often against the change.
Yeah.
But even all that said, I believe change is possible, and I
Yeah.
believe, even if it's those service delivery pieces that can be improved, if we get enough of them, that adds up to a great deal. So
Yeah.
I'll go back to my question. What do you think of this crazy guy, or this crazy guy's vision to
I think, yeah, I think we have to keep trying. I think we've talked about hopelessness and helplessness and learned helplessness. And I think if you really believe in something as strongly as we believe, as we both believe in the NHS, and a lot of people do, and in our will for it to survive, that we can't give up hope. So I definitely, I think it's absolutely great that we can't lose hope and we have to keep trying, even if it feels like it's not going to get us anywhere. Maybe this time it will. I think it is that you've fallen down. Try not to fall into the trap of learned helplessness. You fall back, you fall down, you get back up again. I think the Let's Fix the NHS, the fact that you're trying to get your information and help to amplify NHS voices, people that work in the system, rather than people that are just sitting in offices managing the system. I think that that is something that will help people to come out of that feeling of shouting into the wind, like I said, that there's somebody that's not only willing to listen to them, but then that has the resources and the ability to implement those recommendations or those changes, or just, listen to them and understand the problems and come up with the solutions. And a lot of NHS staff have ideas of their solutions, and there's a lot of innovation. I mean, there's a lot of medical staff that work in health tech innovation because they have these fantastic ideas and they really feel that they could help with the NHS inefficiencies and help to improve it. And it's trying to get those in, just trying to get, those accepted into the system. And so, yeah, whatever help we can get as healthcare staff, we will willingly accept if it means that the system is going to become a better place to work in, both for patients and for staff.
And there's just so many, really silly situations. I was on watching a TikTok live, Dr. Hassan, who's quite popular, and he's a young guy,
Yeah, yeah, it's great.
clearly cares. He's not shy about putting his views out. But he was talking about how much time these young doctors spend looking for a computer that works.
Oh
I mean,
God, yeah.
if you
Yeah,
were to,
looking for a chair to sit on, looking for a computer. I mean, I still had that. I had that all the way through, trying to find a computer, trying to find a pen. I mean, you had your own pens, but sometimes you lost it because everybody jokes in the NHS, you're always losing your pens. Don't spend a lot of money on pens because you will lose it. Yeah, trying to find a computer just to do, it was a 5-minute task. It was something that, this is only going to take me 5 minutes if I can just find a computer to do it. But you spend half an hour looking for a computer, and then you spend another 15 minutes trying to log on because the system is so clunky and slow, and you actually spend an hour doing something that actually only took you 5 minutes to do, but the other 55 minutes was spent trying to do the thing that you wanted to do as opposed to actually doing it.
and then you've got to work an extra 3 hours, and people wonder
Yeah,
why you're
and that
frustrated.
time adds
I
up. Yeah,
mean, how
yeah,
crazy is that?
yeah,
It's just, so those are the little things that really, really add up. And
yeah,
actually, they're probably the things that are expensive. But when you put in the cost of that overtime, which, or the, the lack of delivery, which creates the backlogs. So
mm,
it's costing a great deal, and it isn't actually delivering what it needs to deliver. So these are the bits that drive me absolutely insane, and these are the
yeah,
bits that I think
absolutely.
are possible to do. So let's
Yeah,
just move on to your decision to change your direction.
yeah.
What was the kind of crunch point that you decided, I can't do this any longer?
I wouldn't say it was one crunch point. As I mentioned earlier, I did take a couple of career breaks during the course of my training. And when I look back on it, I do think I was experiencing burnout. I think it was both times that I took a career break, because I took two. There had been some significant life events, but they had just tipped me over the edge. I think I was constantly just working at the edge of my in the NHS, because I was under this, increase under that stress all the time. You're constantly, like I said, you're constantly on alert. So I think ultimately what happened when I actually decided to leave, I wasn't in burnout at all, but I recognized what might happen. I could see the future, and I'd had children. So it was after I had children, and I think I changed a lot. And I think any person that has become a mother will probably say the same thing, that you are a different person after you have children. And I wasn't recognizing myself anymore. And ultimately my goals had changed. What I wanted out of life now included my children and their futures, and me being there for them. And that for me was the most important thing. I couldn't be there. I couldn't continue to prop up a system when my children needed me. I had to make a choice, and I will always choose my family. I think anybody should be able to understand that. But also, and I will say this, it was this frustration of we talked about hope and hopelessness. I think I, at that point, had lost pretty much most of my hope, if not all of it, that the NHS could be fixed. And I felt like I was constantly waiting for things to be better. So when you're in training, you're told life is better when you're a consultant. And then you become a consultant and you think, okay, well, yes, it is a bit better. The hours are a little bit less intense. The workload is a little bit lighter. The responsibility is a lot greater, definitely. But the shift work definitely changes. There's a big shift from being a resident doctor to when you become a consultant. And that does change, but the responsibility increases and the frustration definitely remains and or is actually a lot worse. And for me, I kind of thought, I was at that point, I'm in my early 40s, and I thought, well, I've got a good 20 years left of a career. I can either stay and hope for the best, or I can get out now and I can make a meaningful career elsewhere. And ultimately, I thought, even if with the best will in the world, we make the NHS the best system ever, we fix everything that's wrong with it, I know it's not going to be an overnight fix. And I know it's probably not even going to happen in the 20 years that I have left. And I really hope that it does, but I can't wait around for that anymore. I think now it's time for me to prioritize myself, prioritize my well-being, prioritize my new family, and do something different with my life that isn't going to drain me so much emotionally, physically, and mentally. I was just becoming more and more anxious, and I felt like I wasn't going to be able to give my best anymore that the system and that patients deserved. And I didn't think that was fair on them. And I knew that I wouldn't feel good either. I wasn't feeling good about the fact that I was struggling now to give my best. And, I wasn't able to do that anymore. I just was probably getting to that point where I was burning out. But this time I decided that instead of a career break, it was a permanent break that I needed.
If you think of the skills that you built up, which are considerable over in that discipline, which is intense, is an understatement. But not just your training, but your practice over the years. Put yourself in the shoes of NHS leadership or West Streeting or whoever you want to think. If they could or if you in that position could wave a magic wand and do something to retain the services of Nadia for her full career, not maybe 100%, but at a 50% level, not necessarily in delivery, perhaps in teaching, what would you have done, or what did you wish for that just didn't occur? Or maybe not, maybe nothing.
That's very difficult to answer. I will say that the department that I worked in and my immediate boss at the time that I left was absolutely fantastic in keeping the department morale as high as he could, despite the pressures that he was under. And I definitely didn't have some of the complaints that other people might have in terms of flexibility or lack of understanding from my immediate senior management. He was absolutely fantastic.
Maybe we can get him on here and interview him.
He's probably busy because he's still working. But no, but definitely a lot of, I think that I was fortunate that I worked in a department that had such a fantastic boss at the time. Not everybody is as fortunate. People do have managers that are not as understanding, that don't have that flexibility. If I ever needed to take some time off because I had an urgent issue, there was never any debate about it. It was immediately understood that we are humans, that we are people, that we have other responsibilities, that we are affected by life in the same way as everybody else. And that does and can affect our ability to do our job. And ultimately, as managers, West Streeting, whoever it is that's in charge of the health service, their responsibility is to make sure that the NHS is not just efficient, but the care that's being given is safe. So it's not just we're trying to get X amount of work done, but that work has to be high quality and it has to be safe. And you have to think about the people and the processes that are delivering that. And if you could wave a magic wand to have kept me, I think it would be very difficult. I think I can't really answer that because I had my own personal reasons as well that I wouldn't expect anyone running the health service to fix, my own personal, non-work related reasons for leaving. But definitely I feel, like I said, one of the reasons that I thought it's time to leave now was because I thought it's the change isn't going to happen quickly enough. So when I left, it was just before, I think it was just before Labour or just after Labour had come into power. I can't actually remember now. But before that, we'd had, kind of a decade or so of Conservative power, and they had, or they appeared to on paper have very, very different goals with regards to the NHS. And generally, Labour are known for being a little bit more wanting to invest a little bit more into the NHS. So there was that little bit of hope, I suppose, when they came into power that they are going to. However, I do recall that a lot of the media around that time and a lot of their own sort of policies that they were sort of announcing for healthcare. And I do remember thinking, oh, they're not really saying anything that convinces me that much. I mean, they're saying that they want to fix all these problems that the NHS has faced and that they're going to, like politicians always do, and especially when there's two opposing parties and they always say we're going to do better than what they've just done. But I kind of thought, I'm not convinced, actually. I wasn't convinced by any of the things that they were saying, that they actually had their priorities in the right, that they actually had their priorities straight at all. They were talking about medical school places when we have a massive issue at the moment with resident doctors facing unemployment. And that's because medical school places keep being increased. And you have to remember that once you can increase medical school places, but those graduates that you produce at the end of that have to have jobs to go into. And those jobs have a trajectory that they need to follow. And if you don't have the right number of jobs at each level along that pathway, then you're just creating a bottleneck. And that's why we're facing the issues that we're facing now, where doctors are, for the first time in my career, ever facing unemployment. It was never a thing. One thing that we always used to say was, as doctors, might not be paid the best, but at least we've got job security. That's what we always used to say. And now they can't even say that anymore. It's absolutely ridiculous. So yeah, I felt that the priorities weren't in the right place at all.
And yet on the other side, you've got people leaving for Australia and other places. But part of me thinks that unemployment problem, when people do go into other sectors, there is going to be a challenge where people are leaving for other professions or other countries. And despite the unemployment problem, you get the feeling that at some point it's going to reverse. And then there's going to be a shortage again. And it's just like very, very inefficient planning. And the reasons people go and reasons people, and in your case, very, very, I wonder whether if you'd had more sort of career options with the skill base that you got, what you could be doing is taking that knowledge and that understanding and in a way that worked for you and your family, you could be sharing that and supervising or delivering in a way that's directly related to the experience that you've had. And that, to me, is a loss for someone who's spent all those years to have that experience, that capability. Now, admittedly, you've got so many transferable skills, and maybe just spend a moment talking about what you're doing now, because it is related. In a way, it's related to this conversation, which is the health of a workforce. But maybe you'll explain it a bit more.
Yeah, so I'm working in occupational health now. So it is ultimately, the goal is to keep a healthy workforce, not just in the NHS, in general, keeping the workers of the nation healthy and in work, and being able to understand the difficulties that people's individual health issues the challenges that they might present for them in their working lives, and trying to overcome those and manage those. And there's been lots of reports recently about sort of unemployment rates and people who are off work, long-term sick, and how we're going to get them back to work. And occupational health is going to play a massive role in being able to get people who are off sick back to work, and people who are in work with health issues to stay in work. And that's ultimately what our goal is. And that is physical and mental health issues. So in the NHS, there'll be a lot of people who do experience burnout and work-related stress because of all those problems that we've discussed. And so occupational health, those people will need occupational health as well. For me, it was about using my skills and transferring them in a different way. And it wasn't the anaesthetic skills specifically, but some of the more non-technical skills, we would call them, I suppose, like complex decision making, critical analysis, being able to see systems as a whole, and then identifying what you could fix, at a smaller level. So yeah, and for me, it was also the fact that it was less of a demanding job. It was less high stakes and less intense than anesthetics, which was frontline service provision, and occupational health is a very hands off. We're not managing, we're not treating, we're not fixing people. We're trying to keep them healthy as opposed to fixing them when they're broken. And the actual working practices are also very different. We don't work in hospitals at the coalface, but we're providing advice and consultations and opinions. So practically for me, it worked a lot better because it meant that I didn't have to try and juggle practically service provision around family and my own needs. I can now work from home,
You mean
which means that I can
capable
actually,
of being in the hospital environment, getting
yeah,
to and
yeah.
from and all of that,
Yeah, just
and
all, yeah,
having
I
that
mean,
aspect of family.
yeah, you can't do anesthetics from home. There's very little you can do. And being able to take time off, there's a certain number of, not everybody can take time off. And most jobs are like that. It's not just healthcare. You do need workers there to keep the, whatever it is, the business, the organization going and the service going. But just not having that extra pressure of having to juggle those service demands. And as I said, trying to kind of keep the service going despite it being inefficient, with now my own increased demands of wanting to make sure that I look after myself and also that I look after my family. So occupational health has allowed me to continue to feel like I'm contributing, but instead of helping people on an individual level, the aim is to help keep people healthy as a whole and keep the workforce healthy. And potentially, yes, actually, my goal is, because I want to try and help the system, the NHS in this case, I do want to try and help it get better. And now, because I've got a less demanding job, I now have that space, that energy to be able to spend that time. I wouldn't be able to probably have time to do this interview with you if I was still in my old job, because I'd just be exhausted and juggling. And whereas now I can, and now I've been able to suddenly, I have all this extra energy now that I can spend, and that helps me to kind of feel like I'm being more productive as well with my life, which is great. So yeah, it was, practical reasons, and also for me to be able to meet my goals and aspirations that I had in trying to fix a system and trying to make systems more efficient.
I think it's exciting that you're still in health and you're still in this country that and that you can focus on yourself and your family, but still giving back. So you work for a company that
Yeah.
delivers occupational health,
Yes. Yeah. I work for yeah. Yeah.
a
Yeah.
big.
So I it's a big company, yeah. It's a one. There are lots and lots of big and small occupational health companies. There's also occupational health in the NHS. So occupational health is a very, very unique specialty in that it has, obviously, the NHS needs occupational health for its staff, but every organisation, every employer, larger employer will need occupational health services. So there is also a big section of occupational health provision in the private industry for those. And so there are private providers as well. So yeah, I work for one of the larger occupational health providers, but as I said, there are lots and lots and lots across the UK. Some are very small, some are very, very big. And essentially, they have clients, businesses who they provide services to, and I work for the company as an employee to provide those services.
And how many days a week are you doing? What typically is your?
I work 3 days a week because for me at the moment with two young children, that's what works for me. It gives me that right balance. And I probably will increase it as they get older. Once they're in school, I'll have a little bit more time. I still would like a little bit of a nice work-life balance. And it's one of those specialties that I can do that. So yeah, but ultimately my goal is to not just work in occupational health, it's to provide and get a little bit more involved in management, in trying to fix systemic issues, because it's something I'm very passionate about, because I think a healthy system means a healthy workforce. And having been an individual who worked in an unhealthy system and felt the effects of that on myself, it's something that I'm very passionate about changing and improving for people. And that goes back to me being a 16, 17-year-old wanting to help people.
It's I think it's really nice that you're still thinking of that systems level approach, and your current role you can deliver that at a different coalface, but it's still direct. But that vast experience is I think incredibly valuable, and we need people like you to be looking at these systems and saying, how can we make it work for everybody and
Yeah.
work for the patients? I liked what you said earlier about it's not just how many operations, are they safe, are they delivering? The goal for this platform is to actually go into other areas as well. Although the NHS, I believe that you fix the NHS by reducing the burden upon it. So there's a program I've mentioned it a couple of times on here, where in Manchester, I think it's called Live Well, and Andy Burnham, the mayor, and the senior management team in Manchester, they're pushing this as a way of getting people to be more responsible for their own health with the support of community organizations. That includes the housing and the religious or groups that they're part of. That could be taking the blood pressure and weight and making sure people are exercising and eating well. And all of that has an effect. If we can have a nation of people who are more healthy, myself included,
Yeah.
then that is really, really important.
Yes.
We have to, tackle things like discharge, as we've talked about, and care. I'm very passionate, obviously, about stroke as a result of my mother's situation, and I help facilitate a regular local meeting. I don't do it all now, but something called Different Strokes for young stroke survivors. So you learn an awful lot about how people are treated in the workplace when they have, particularly young, of working age, have had a stroke, and for us to create a country that works for everyone, we have to rebalance our economics. We have to create more jobs. Or the fact that we have a cost of living crisis and rising prices, that puts stress on people. It means they need to work more jobs or more hours or multiple jobs. And all of that means they're not as healthy as they need to be. So
Absolutely, yeah.
achieving work-life balance and surviving, sometimes are at odds.
Yeah.
And, that part of this sort of systems approach, of course, the NHS is not fixable. It's like the Forth Road Bridge. You've got to keep painting it. And sometimes different parts need attention. But if people can be heading in the right direction and working together, and with a positive attitude as opposed to giving up. And I know people who go in every day are not giving up, but in terms of creating change that we need and change that's worthwhile, we've got to have that positive attitude and we've got to believe it's possible. And therefore, I know it will be impossible to fix the NHS, but if we can create many, many fixes collectively, even if they're small, they can add up to a great deal. And if that is giving people quality of life and more fulfillment and more enjoyment, and people getting a hip replacement or whatever it is that they need or not needing one, then if you save one life or 1,000, what's the difference? There's not much difference really, just scale. So this has been amazing. I really want to thank you. I know you've got the girls to go to, and we have had a really great discussion. And perhaps at some point, the goal is to do panel discussions and cover very specific subjects. So it would be great to have you back, and part of building this community, please tell other people. And if you've got other
I will
people
do, yes.
you'd want to suggest. But and then finally, TikTok. Just mention your TikTok before we go, because that's how we got in touch. I'm new TikToker, but I am quite excited by that platform, particularly for short conversations, but and short content. But yeah, what's your thoughts on TikTok?
I think it's great. I think social media generally is such a powerful tool for people to use. My first use of social media was back in 2015, 2016 during the junior doctor contract dispute. I was actually part of an organisation at that time called Justice for Health, took the health secretary to court at that time for a judicial review of the imposition of the contract. and we had to crowdfund, and we raised £250,000 in crowdfunding through social media efforts. And it wasn't just me. Obviously, I was a group of 5 people, and then we had a massive support team of doctors. We were all just junior doctors working, but we had so much support, and we raised all of that money through social media. So I think it's a most powerful tool in the hands of the common person, because we've never been able to control media narrative generally, and now suddenly we have found a voice. And TikTok is something that I again have just become involved in. I've used it before, and I just initially have gotten involved because I found it fun. I find it's a nice bit of downtime sometimes to scroll, but actually I think it's so powerful as well in terms of the message. It's just, it's about moving with the times. In the past, people use other social media platforms, and TikTok is another one of those. Seeing people. So yeah, I think delivering messages is such a powerful tool to use. And so generally my page is, I'm trying not to be too serious about it. There may be the odd political thought because I'm very passionate, especially about the NHS when it comes to that. But it's a little bit about also just showing myself as a person, as a human, as a mum, as somebody who just is living the same life as everybody else. And just because we're doctors, we're still people at the end of the day. And ultimately that's what I'm trying to show, is that I laugh at the same things that other people laugh at. I cry at the same things that other people cry at. I have the same dreams that other people have. And being a doctor doesn't mean that we're different somehow to everybody else. And it's trying to get that across, and at the same time just have a little bit of fun making videos, but also using it for promotion. So a lot of people have got very limited understanding of occupational health. And so I thought, actually, why don't I use it to try and get a little bit more information about what occupational health is, what do we do, to help members of the public and employers to understand what our purpose is and how we can actually help a little bit more. Because I see people, or I consult with people every day as part of my job, and a lot of them don't really know why they're having a referral or what to expect, or are you here to fix my health issues, or what are you trying to do? Do you work for my employer? So I'm trying to sort of bust a few myths about occupational health and give a little bit more of an understanding of what we do, both for the public and also for other doctors that are out there that might be thinking about their career options and what they want to do, both within and outside the NHS. Just to say, this is a specialty. We're very small, but we're very important, and this is what we do. And if it's something that interests people, then that's something that they can look to get into.
I think it's great. And I think it's important because, again, if we can have a healthy workforce and if people can understand the benefits from an employer's perspective or the employee, or people who are, an awful lot of people have portfolio careers and are self-employed, and these issues still apply to them, even if they're not directly employed by one organization. And
absolutely.
So the more, you're an amazing communicator, and that I think is the more people understand these things, the better. And finally, just on the TikTok or YouTube and Instagram, I think TikTok's a different platform, and I really learned about it from Dr. Zainab Hussain, who is the most amazing GP who is in the local practice. That was the practice of grew up going to this local practice in a little place, Kidsgrove, which is not far from where I am right now. And I interviewed her. So some of the shorts that are on TikTok are extracted from that interview. And we'll be doing another one. And maybe at some point, if we do a panel discussion, you'll meet her. She's amazing, and also a great communicator. And what's exciting is there's so much that can be done health-wise from better understanding and better knowledge, not just people Googling things, but actually having good advice from people who really know. You can
absolutely.
go down rabbit warrens and you can get scary information. The internet is a scary thing if it is just open and unbridled. But people who are experts in their field, who are knowledgeable and stunning communicators, that's why I think Instagram, Facebook, TikTok, all of these platforms, YouTube especially, I think they're incredible. And I'm very grateful for them. for meeting you. So,
Thank you.
so thank you very much,
Thank you so
Nadia.
much. Thank you.
This has been great, and we'll talk again.
All right. Thanks so much.